Hello. Through our life, so many of the decisions that we make are quite simple. What to wear, what to eat. But sometimes as we age, we're faced with more difficult decisions. Like, what should the end of my life be like? We have gathered today a group of people that are passionate about making a great ending in people's life. They're passionate about quality of life at end of life. And I would like to introduce you to some friends of mine today. I met Susan Rowland not long ago.
That's right.
She's actually related to one of our residents. Dr. Rowland has her PhD in clinical psychology as well as an RN. She's a doctor and a nurse. She's a psychologist and also works ICU several days a week. And I tell her that is what really keeps her real. She also teaches medical ethics and end-of-life issues in the Cincinnati Medical College.
That's
right. For fun, she kayaks as well as bike rides, and she's very active and fit. Our next guest is not really a guest here. He finds his way around here quite easily. That's Dr. Eugenio Machado, known as Dr. Gene Machado. He's my boss, as well as many other people here, because he's the medical director. He has many years of medical experience, and he also has many years of experience in making phenomenal birthday cakes. Oh. Our next guest is Molly Pittman. She has had this name only a year, as she got married about a year ago, right, Molly?
That's right.
She's the lead social worker here in Independent Living, and she has worked with many, many people on the issues that we're going to discuss today.
That's right.
I'm going to throw some questions out to some of our residents, as well as this group here. We'll start with a question. What are advance directives, and why should someone have them?
Well, an advance directive is a document that a resident or a non-resident, anyone for that matter, puts together that does exactly what it says. It makes a directive in advance of when they need it. And an advance directive can help people do several things. One of those things is to designate a person that would help make healthcare decisions on their behalf if there becomes a time when they're not able to do that. Taking into consideration what they know about that person, what that person's beliefs are, and also taking into consideration the other aspect of an advance directive, which is the living will. And the living will is a document that helps people identify and document preferences that they have or preferences that they don't have regarding certain treatments that they might need to consider towards the end of life, such as nutrition or hydration. So it's important to have these documents for two reasons. One, so that everyone knows, your family and your medical team, what it is that your wishes are, so that they can make sure to actively advocate for you and for what your wishes are if there comes a time when they need to do that.
Are there any other choices that should be included in this document?
The one thing I like about having a living will that I think sets up some expectations in advance is the living will says this is what I don't want to have happen, which makes it easier to say that I've got choices what I do want to have happen. And that's what is in the living will. It makes those choices. The quality of life issues that come at end of life, a living will says, for some, says, I don't want to be kept alive if I'm not able to understand that I'm alive. That is the lowest quality of life for me, and I choose not to have that. That is something that I don't want. But there are many choices along the way in quality of life, and that's what a lot of people don't know, and that's what we're here to discuss. So I think a living will sets up the bottom rung this is what, if I am this way, then I would prefer to not have you do anything more to me to make, that's the bottom rung. So
the great thing about an advance directive is that it gives you control. There's all of us know, living in a community like this, that you are not necessarily guaranteed control until the end of life. Your ability to make decisions can change. You can get really sick. You can be in a very stressful situation at a time of major illness where it's hard to make really hardcore decisions. So what an advance directive gives you is the ability well ahead of time to sit down when you have your cognitive function, when you're able to make good decisions, to really think out, what do I really want? Do I want to be resuscitated? Do I want to spend the last 5 years of my life in a nursing home being fed by a tube? And if you make those decisions well ahead of time and you document them and you let your family know or your loved ones know what your decision is, it provides you, a much better quality of life.
What are some possible goals for someone as far as their medical care when they're at the end of life?
The main goal is to avoid suffering. At least in my mind, and I think if you ask the next 10 persons that you meet, that should be the main goal. As you know, medicine this day and age is very advanced. We have a possible answer for everything. A lot of times the possible answers really are not that fruitful, but there are things that that can be done for everything, to sit and make your decision ahead of time as to what extent do you want your life prolonged and at what cost. That's what the beauty of an advance directive is.
Those are advanced choices. And
Exactly.
we're in control of really one thing, comfort through the whole thing, and we can get that done. And if we give up that control by not telling anybody what we want and just moving through things blindly, and we have physicians and doctors and nurses in the hospitals, and they do what they do best, which is stop things from happening that are happening anyway. So having an advance directive is letting people know up front what those choices are along the way.
I'm going to get real here for a moment. My dad is 91 and has very advanced cancer. And Dr. Machado, pretend that I came with my dad to see you. What might you possibly say to help us through this decision-making process?
Well, the first thing, this is all postulation because there's all kinds of advanced cancer, but advanced cancer in a 91-year-old, the first thing to discuss is what is your code status. Should, the good Lord find it's time for your heart to stop, right now, a week from now, do we resuscitate you? And we'll go over resuscitation later, but resuscitation, is a major process that at 91, the outcome is not the greatest in the best of circumstances. So
what do you think the outcome would be for a 91-year-old?
Hard to give you really good numbers, but just recently, I think this week, the Journal of American Medical Association did an article where they went over resuscitations in the hospitals for the past, I think it was for the year between May 2006 and May 2007. And of 12,000 resuscitations, only 846 got discharged from the hospital. So
And
that's
what
a
age
9%.
group?
And that's all age groups.
Oh.
So that's a 9% chance of survival in all age groups out of the hospital. And of those 826, 25% died within 6 months. So that's for all age groups, including neonates, a lot of 45-year-olds having their first heart attacks. When you talk about a 90-some-year-old, with frail bones, one of the processes of resuscitation is that we compress the heart. How many of folks in here, have had a simple fall and fracture ribs? When Dr. Machado is compressing the heart, chances are that you're going to fracture ribs, and you can think of the pain associated with that. And the bottom line is, the end result is that, you're a nurse in the ICU. You tell me how many 91-year-olds that you resuscitated that actually, had a quality of life afterwards. I mean, I can't think of any.
No. And if we bring them back, many times they don't come back to better, they come back to worse. And at the very worst, they don't even know they're back.
Now, I've heard people say, CPR is just a simple thing, and of course if my heart stops, I want them to attempt it. Is it really that simple?
No, it's an involved process, because the body works like a car. Everything is joined together, lungs and kidneys, and when it's kind of like parking a car on a steep hill. And the car has 100,000 miles on it and rusty brakes. It's got little reserve, and you've got a good quality of life up here and no quality of life where you've been brought back and you don't even know that you're back. So that's down here. You've got a car with 100,000 miles on it, rusty brakes, and you're going to resuscitate that so that it can go all the way down here anyway. People make choices not to do that and say, where do I want to get stuck? I think I want to get stuck right here. I can deal with my life right now. I don't want to go to a lower quality of life. If I'm going to have to exit this picture, I'm going to exit now if something happens, and not wait until I am resuscitated and don't even know I'm alive.
If my dad decides to avoid CPR, what might be some choices that he could make that would make his last chapter of his metaphorical book a really good one?
Well, I think one of the myths that I deal with a lot is the thought that if I don't want CPR, that I won't receive any care. And that's a scary thing, to think that at the end of my life, when I might be uncomfortable, that I would be left behind and that I wouldn't receive the care that I want. And
that's
so
totally
it's
untrue.
Right. And so it's important to negate that myth, that they're unrelated, that I can say I don't want CPR, yet I can still, have the treatments that I need that will help me be comfortable and help me have as much of a quality of life as I can, as long as I'm here, including, oxygen. If I want to go to the hospital, I can. If I'm saying I don't want CPR, what I'm saying is only CPR. And so I think it's important also to talk with your physician regarding your own personal circumstances. Dr. Machado mentioned that it's hard to give a blanket answer that, your circumstance will result in this. And so it's important to talk with your doctor, who knows your history and knows what other medical conditions you have, what other procedures you've had, what your age is, what your overall medical circumstances are, so that together you can talk about what your thoughts are, what your fears are, and take that medical expertise to help you really have an educated idea of what it is that you want.
Yeah, and Molly's point, I just need to hammer that point down, because it's a very important point. No CPR does not mean no care.
That's right.
Okay, if you have CPR, and if your dad decided on a no CPR, and tomorrow he develops a bleeding ulcer, or tomorrow he develops pneumonia, he's going to get treatment. And chances are that I'm going to take care of that pneumonia, take care of that bleeding ulcer. It does not mean no treatment. We still treat aggressively, short of bringing him back to life, if the good Lord finds it's time for him to go.
And that's a point that's overlooked sometimes in the hospital, in the ICU. People say, well, can I still have antibiotics? Can I still have an operation? Can I still have everything? You can have everything except two things: cardiopulmonary resuscitation and a tube down your throat. everything else goes. So Molly, your point's well taken. People think it means backing up and moving away.
Right.
They also think it means giving up. And, well, I've given up. And 99.9% of the people I deal with, they never give up. We just move in a different direction just as aggressively with just as many aces in our back pocket for exactly the things that you said, secretions, pain, everything. And that's quality of life. So you get everything except resuscitation. And people think that no CPR means no care.
And then to follow on that is not only not giving up, but I think it adds another alternative. It's actually giving hope, because a lot of folks are fearful of going into the hospital and having a bad outcome and ending up on a respirator or ending up with tubes in the ICU, having a cardiopulmonary arrest and spending the last 2 months of their lives in an ICU. This relieves that fear. I can go to the hospital, Dr. Machado can take care of my pneumonia, but if my heart stops, I'm not going to end up in an ICU, with tubes. So it's not really giving up. It's really determining what your expectations are, making sure that your physician and your care coordinators are on the same page, and that for me personally, if I was making that decision, it would be a relief.
Yeah.
If someone really did not enjoy the hospital experience, they hated going through the emergency room, they just did not enjoy being in the hospital, would it be possible for them to get care outside of a hospital setting when they were at the end of their life?
Absolutely. And we are extremely blessed by living in Riderwood, that we have those facilities. I mean, there's the level of care, that I can provide at Renaissance Gardens is, it's outstanding. And, there are a lot of things, that I can do at Renaissance Gardens that most other physicians don't have that luxury, that to provide that level of care for their patients, they need to be in a hospital situation. So, there is that option. And in Renaissance Gardens, for a lot of folks that have experienced Renaissance Gardens, a lot of our residents that have experienced Renaissance Gardens, they come to know it as home also. I mean, there are a lot of patients that I have in the hospital that I tell them, I'll be discharging you back to Riderwood. You're not going to your apartment right away. We need to get you up to speed in Renaissance Gardens, and they tell me, oh, that's home anyway. So, we are blessed, that we have those facilities here.
What I was impressed about Riderwood with my aunt is that there's someone to look in on her all the time, whether she was in independent nursing, if she had independent living, if she had something wrong, she could make an appointment and be on campus to see a physician. I saw you the next day. I flew in one day, took a look at a situation, and said, we need to get seen. And sure enough, right away, we were seen, and that's how we met each other. But there are different levels of care here, and once you come here, it's kind of like a full concierge service 24/7. There's somebody that addresses your needs all the time, so I'm really lucky that she's here.
Well, we've talked about some common myths of end of life. We've talked about some possible goals for people in the end of life, or that last chapter of their life book. But we may have just started stimulating some questions in those of you that are watching this. And if that's the case and you really want more information, you still have a lot of questions buzzing around in your head, don't hesitate to call your social worker. And if you don't know who your social worker is, the front desk of your community can tell you who that social worker is. At your next visit with your physician or nurse practitioner, don't hesitate to ask them for resources or the questions that you have. All of us have had multiple discussions with many of you many, many times, and we're happy to have those discussions or answer any questions that you have.
It is very important for me to have advanced directives because I feel that as long as I'm in control of my life, I can be in control of my death as well.
I had had a heart attack at 84, and I didn't have one. And at that time, my husband, he didn't know what to say or how to answer the questions as to what I wanted.
The husband and the wife and the children should discuss these things and have everyone be aware of what the wishes are of the person who is ill.
I don't know, when I was 80, I began to think I need to make preparations for the fact that I'm not going to live forever, even though my father lived to be 100. Maybe I do have 20 more years to live.
I wanted to ensure that my well-being and whatever necessities I need in life would be taken care of by me. And this is what this is why I feel that I need to make these decisions while I'm in control.
We started making plans shortly after we arrived here at Riderwood because the thought with Riderwood is this is your last stopping place. You may be here for 5 years, you might be here for 15 years.
I feel that this is a gift to myself and to my family, not to have to worry about what to do when the time comes.
We do not want any kind of artificial treatments, not any kind of tubes or anything that would be just to sustain life for a temporary time.
No life-sustaining treatments, no CPR, as I call it, no wiring up.
I like to think that people can have a really positive experience in their last hours.
What might be the ideal solution for me is to actually be sitting in my apartment at an old age, having my breakfast, and then just nodding off.
Being in a place where I'm comfortable and around people.
The ideal end of life for me would be to go to bed one night and never wake up.
It's just a natural way to die, and to us it makes a lot of sense. And we prepared our families for that they might say, oh, we want to keep you living as long as possible. We do not choose to live when we don't have any quality of life.
The main thing is, for me, is being kept comfortable and knowing what my problem is. I do want to know. I want the doctors to be honest with me.
I think that's part of dying without suffering and without worrying. Is everybody doing the right thing?
And I know that it's a big advantage for my children to know that they know exactly what I want to have done.
They're going to be concerned about what's going to happen as far as the funeral and everything goes. And if they have thought about it in advance and you've told them what your desires are, then things go more smoothly.
I wish that more people would be receptive to even talk about these kinds of things. They often put it aside and say, oh, I'll let my family worry about that. But you can't realize how much importance it is to the family to know where you're coming from and what you want to have done.
Well, I think everybody comes from a different place, and I try to be very respectful of what people's beliefs are, what their spiritual life has been, and I would not want to impose my thinking on them, but I would want to know, what their concerns are, support them, and show them what the options can be.
What I would do, I certainly think that it's very important to gather as much information as I can And a lot of it is available through these different resources right here in Riderwood.
And there's a lot of material available to work with this kind of, it's not easy because there are many different aspects of the end-of-life work. I mean, it has to do with your physical condition, what your power of attorney would be, and your executive of your estate, and consultants that you have, and doctors, and so on.
I bring up these subjects after I've gone to a meeting, informative meeting of one kind or another, and I realize that a lot of people don't get to these meetings that are so important. And it's so essential to be well informed to make the right decision.
I think they could explore with the social workers here. I think they could explore with the chaplains. I think they could explore with some of the other residents.
Well, I think it's important to talk about these things with these people, is that I've learned a lot in ways that I was not aware of.
And it took me months and months. I agonized over this to write exactly what I wanted, and when I finally did, it was such a relief for me. And now I feel so much freer in my mind that I've done what needed to be done.
And I'm all satisfied now. Everything is all settled. And at this point, I feel a great relief.
Once you get over the hurdle of thinking through what you need to do, you get it out, you get it done, and you're finished. And you can enjoy the rest of your life in this wonderful community.